available to the public. So if anyone objects to being recorded, if they could leave the meeting, please. But obviously we would prefer that everyone stayed. So my name is James Brent, and it's my pleasure to be the chairman of NDHT. You will shortly hear from our Deputy Chief Executive, Chris Tidman, who is standing in for Suzanne Tracy, who unfortunately is not able to join us today for personal reasons. And Chris will give us an overview of 2020-21. You'll then hear from Angela Hibbard, our Chief Finance Officer, who will speak about the annual accounts. And she will be followed by Jason Lugg, the Trust Director of Nursing, who's filling in for Carolyn Mills, our Chief Nursing Officer. And Jason will talk about the quality of our services. We'll then go back to Suzanne, we'll go to Chris for a look forward at the year ahead. It's fantastic to see so many of you joining us today for this meeting. We had hoped this meeting would take place in person, but alas, the pandemic has conspired against us, and we felt it was inappropriate to do so. Nevertheless, we have good virtual attendance and a mixed audience, including some staff, local people and local authority colleagues. So if I could welcome all of you and thank you for sparing your time. We received 4 questions ahead of the meeting, and we will answer these at the end of the meeting. We will make time available to hear from all of you. So if you have any questions as we go through, if you could put it into the chat function, but we'll take the questions at the end of the meeting rather than interrupt the flow. Tonight is an important opportunity to look at what we've achieved over the last year, and we look forward to our plans for the rest of 2021-2022. It goes without saying that it's been a year like no other. I've been in total awe of how our NHS staff, and indeed staff across the care sector, have worked together to respond to the pandemic, and of how amazing local people have been in supporting us to be our very best for them. I want to take the time on behalf of the Trust Board and the communities we serve to say thank you to everybody who is part of the NDH team and everyone who supports us. The commitment, compassion and flexibility we have seen and continue to see is nothing short of extraordinary. There have been many learnings that we've taken from this pandemic experience, and these will be really important for us going forward. This challenging time has shown us more than ever how crucial it is to recognise the incredible work our health and care staff do and to demonstrate that we value them. It has also shown us how much more we can achieve in committed partnerships with shared ambitions than we could do alone. We should also acknowledge that things will continue to be tough for some time, and I encourage everybody to continue to show empathy and kindness to our staff in Northern Devon and elsewhere. We are now working hard to reset and recover our services and our staff on a sustainable basis. Many people are waiting longer for their care than we would like, and addressing this is of the utmost importance to us. There are some really innovative things happening in Northern Devon to help us to do this, such as the drive-through patient-initiated follow-ups, or PIFU. That's the first acronym I've used today, and improving how we offer remote appointments. From a personal standpoint, I'll be stepping down as chairman at the end of March 2022, and I do feel really proud of everything we've achieved together. And we'll hand the baton to somebody new. They will be privileged to serve our population, and I will be envious of them. There is certainly much more to do in Northern Devon. We need to keep on working together to reduce health inequalities, and we need to do this by averaging up and not averaging down. But I do feel hugely optimistic about the healthcare in Devon. Despite the challenges we have the most incredible people at NDHT, and we have significant opportunities in coming years, including funding for our estates, for our hospital, and for technology. And we have a great opportunity to work much better together as part of the Devon ICS. We also have our proposed integration of NDHT and Royal Devon and Exeter. With shared challenges, we have recognised that we will be stronger together and we are undertaking the work we need to do to demonstrate the benefits of the proposed integration. It is really important to me as we look forward that we preserve what's special in Northern Devon and we continue to take a best of both approach to integration, learning from each other. Staff in Northern Devon, for example, have developed incredible innovations to help mitigate the impact of remoteness on our patients. We do have some incredibly passionate staff and members of the local community, and I really encourage you, if the merger goes ahead, to become members of the new trust. And if you have the time and can contribute to the role, to stand as governors to represent Northern Devon, the Northern Devon population within the proposed integrated organisation, it is a great opportunity to further increase the engagement between the community and the two trusts, which become one. Information will be shared about all of this through our stakeholder communications in due course. I'm going to finish the introductions by giving an overview of the membership of the Trust Board. We have a joint executive team for NDHT, covering both NDHT and Royal Devon and Exeter. I don't know, we've got some slides, I think, which will pop up showing some mugshots. We have Suzanne Tracy, Adrian Harris and Hannah Foster were already in joint roles, but in January 2021, we added 3 further joint roles. Angela Hibbard, who was previously Director of Finance at NDHT, becomes the Chief Finance Officer of both trusts. We also have Chris Tidman, who has become the Deputy Chief Executive Officer of both trusts, and Carolyn Mills, who had previously worked at NDHT, has returned as the Chief Nursing Officer of both trusts. Pete Adey, our Chief Operating Officer, retired at the end of March, and we welcome John Palmer to his role initially in an interim capacity. We were able to announce in July that John has been successful in the substantive recruitment process for the role, and we're very pleased to have him on board as part of the team. To support our joint executive team and to provide strong leadership presence at our northern and eastern sites, we have appointed trust directors for NDHT and the Royal Devon and Exeter. And my congratulations at NDHT to Karen Davies, appointed as the Medical Director, Jason Lugg, who's with us today, as the Director of Nursing, and Heather Brazier as the Director of Operations. And just before I move on, I'd like to recognise the contribution made by other colleagues. So as I mentioned, Pete Adey, who was our Chief Operating Officer, retired at the end of the year, and Darren Alcorn, who was the Chief Nurse for NDHT, left in September 2020, but he continues to support our population in his capacity as Chief Nurse for the Devon system. And also our thanks to Andrea Bell, who provided strong interim nursing leadership at NDHT. So if I can thank all of them. There are a number of changes happening to the non-executive board team at the end of the year also. As I've mentioned, I'll be stepping down from my role in March 2022, and at the same time, 3 other colleagues will step down who have made a major contribution to NDHT in the form of Robert Down, Tim Douglas Riley, our Senior Independent Director, and Pauline Green, our Vice Chairman. As we move towards the proposed integration with the Royal Devon and Exeter, and as terms of office expire, our 2 boards will gradually come together to form a new board. Those of you who attend will know that the 2 boards are currently meeting together. The new board will be made up of 7 non-executive directors and the chairman. As I mentioned, I'd like to really thank Robert, Tim and Pauline for everything they've brought to the NDHT board during their extended terms. I'm confident that together our executive and non-executive directors form a board with a wealth of knowledge and experience, and with an absolute commitment to doing the very best we can for the population of Northern Devon. I will now pass across to Chris, who will give an overview of the organisation as well as the key developments and challenges in 2020-21. Thank you. Chris.
Thank you, James. So my name is Chris Tidman. I'm the Deputy Chief Executive. So I'm standing in this evening for Suzanne. As James has said, she can't be here for personal circumstances tonight, but again, I know she would have dearly loved to have been here to reflect on what has been just a quite extraordinary year. Next slide, please. So visions and values, you often see these in annual reports and plans, but I think this year more than any has really embodied what the NHS is about. I joined, as James has said, Northern Devon in January, and immediately wherever I went, whether it was in the hospital or to our community hospitals in and around North Devon, I saw some of these values in spades. So I think it's worth just reflecting on them, because I think this year more than any has really demonstrated the importance of having these values as an NHS family. And you will see there, as we come together and look to integrate with the RD&E, it's really important that we have a common set of values that bind us. Next slide, please. You will all know, the map of Northern Devon, the catchment. I think the thing I would draw out here is clearly we have NDDH in Barnstaple, but our whole system is effectively a series of microsystems of people working every day with patients in their own homes and communities. And it's really important that we get out and we recognise this is a whole system. It's not just how the hospital operates. It's all about community hospitals, and it's the teams that interact with people in their communities every day. Obviously, we have an influx of tourists, and those of us who drive around Northern Devon in the summer will recognise that. But the vast majority of the patients we see, there's almost 93% are patients from our own area. Next slide, please. Numbers cannot really do justice to the year that we've just seen. If you kind of do some crazy maths and aggregate the total number of patient interactions and divide them by total numbers of days in the year, this isn't far off 1,000 patient interactions per day. So you just stand back and look at that, it's phenomenal. But as I say, numbers alone don't really describe the kind of year that we've had and our staff have had. Next slide, please. So there's so many highlights we can draw on, but I have to just start by just recognising what our teams have been through and how they've kind of come through that with fantastic pride and resilience. None of us could have ever really predicted the year that we've had, but whether you're the intensive care team that were shortlisted for a Who Cares Wins award, or whether you're the portering team or the cleaning team, or you work on Rober Award, or you work at South Molton Community Hospital, wherever you work, everyone has played their part in helping, look after our patients and community in the most, incredible, stressful circumstances. So it has been a whole team effort, but it's absolutely right that, we do recognise people that have gone the extra mile. And I'll talk a little bit about the future and what we're looking to do to support our staff. But, what our staff have been through and what they've done in the most trying of circumstances is quite extraordinary. And we will continue to put our staff and their welfare at the very centre of our plans as we move forward. Obviously, the pandemic has been, almost 100% of our focus. Despite that, we've had to still carry on building for the future. So on top of trying to manage the pandemic, work also began on a really exciting 5-year new hospital build programme, which we've called our Future Hospital Programme. Those of you that will know North Devon District Hospital will know that it's really well maintained. It works, but it's quite cramped in some areas. It's not modern and fit for purpose. It's fabulous now that we've submitted our strategic outline case and we're very hopeful that we'll get the green light to move to the next stage, which is an outline business case stage, and that will enable us to really build fit for purpose theatres, maternity units, scientific blocks, etc., which will really help us keep our facilities to be absolutely top notch for the next 20-30 years. In terms of our staff survey, we had a fantastic set of results. We ranked first in the country for support from immediate managers, and actually on the whole we were kind of upper quartile in most of the indicators. So I think a fabulous set of results there, but again, not complacent, because we know we have to keep on supporting our staff through what is still a really difficult time. Next slide, please. So, as I mentioned before, our intensive care team were shortlisted, but they weren't the only ones. We had our rheumatology team, the ROBA award team, the breast care team were all shortlisted for awards, and we continue to nominate our teams because recognition is really important. I think sometimes when you're going through a crisis, you also see sometimes some fantastic innovation and opportunities that emerge. We had a fabulous drive-through facility that was opened at NDHT in December. I've been to see it. Some of you may have seen it on the news. It really is proving to be really popular with our patients. So we'll continue to look to innovate. And again, while we're yet to see, friends and family tests recover to pre-pandemic levels, our overall score remains really positive. In December to February, there was something like 97% of patients saying that they would recommend. So moving on, next slide. So obviously the integration between the RD&E and Northern Devon continues. In December, we got the green light from our regulators to move to the next stage. We're now developing a more detailed integration business case, and that will describe how we can come together and be a single integrated organisation and the benefits that will bring to both organisations. Although we aim to be one organisation from next April, subject to all the necessary approvals, I think we have to recognise that you can't just flick a switch and suddenly you have one culture and one team. So this will take time, and we're prepared to give teams the time to do this properly and build the relationships and the trust that you need to really develop thriving, innovative services. So we'll see this really develop over the coming years. And to support this next stage of work, it's been really important that we put the right people in place. And as James has said, we've now got one integrated executive team and trust leadership teams on both the RD&E and the North Devon sites to make sure that we retain that level of local management. Next slide. It's so important that we embrace the future. So in March 2021, we received approval of national funding, so we could roll out the MyCare programme that has been successfully rolled out at the RD&E, to roll that out at Northern Devon. So we're all operating from one electronic patient record system. But we've been really keen to stress this isn't just about I guess IT and software and computers and removing hard records. It really is an opportunity for us to think quite creatively about how we can deliver care, sometimes being delivered virtually, but being on one common system gives you the opportunity of developing common pathways and standardising really good outcomes for patients. So this is great news for our patients and the North Devon community. I think I've covered off those points actually. So, I mean, the most important thing is, whilst it will obviously enable an efficient transfer of information, ultimately it's about safety. It enables us to have some key indicators as to when care is safe, and it flags warnings. It also avoids some of the errors that you get when people are doing handwritten prescriptions and notes. So, it's been demonstrated internationally this is a much safer way of delivering care. But beyond that, we are seeing this as a great tool to be innovative and to look to do even more than what we do at the moment. Next slide. Really important that we recognise that we're not islands. We don't operate in our own bubbles. It is important we work in partnership with others. In March, we confirmed that we'd established what we call a strategic alliance, and that is between North Devon, RD&E and Torbay in South Devon. So it's what we call a provider collaborative, and that's just making sure that we offer mutual aid to each other, but more than that, we look to design sustainable services for each other. And it's really just recognising that together we can actually achieve a lot more for our broader population. So we've been working across what we call the SEND network, South East North Devon, for some time. This is really a way of trying to formalise it a bit more. And we'll continue to use this planning platform, particularly as we try and develop more integrated services across Devon. Next slide, please. And the next slide, please, is the annual accounts. So with that, I'll come back and talk a little bit about the future, but I'll hand over to Angela Hibbard. So Angela, over to you.
Thank you very much, Chris. And Chris has already introduced me to you. So I'm the Chief Finance Officer and hopefully a familiar face to many of you now, as I think this is now my 4th AGM. And so it's great to see some familiar faces myself. As James and Chris have already said, sorry, do you want to go on to the first slide, please? 2021 was an exceptional year due to COVID, and this was reflected in the financial arrangements for the year as well. A temporary national finance regime was put in place based on the actual cost of delivering services, plus the additional cost to respond to COVID, which for North Devon was 8.5 million, which I'll refer back to in a moment. At the same time, the annual requirement for annual savings programmes was paused nationally. So this ensured that all the Trust's efforts was focused on the pandemic response, and decision making was agile as funding was not a constraining factor, but within an appropriate level of financial control and governance. This enabled the Trust to deliver against the break-even requirements of this regime with a very small surplus in the year of 41,000. It was also an exceptional year for capital funding, as funds were made available to support some of the infrastructure changes required. And again, I'll come on to the detail of that shortly. The Trust successfully delivered a 24 million capital programme in the year, which I think is remarkable, as it's 4 times the normal amount of capital spending that North Devon would have previously spent. Can we go on to the next slide, please? So in terms of the financial snapshot of where we receive our income from, the majority under this new regime or temporary regime still flowed through the clinical commissioning groups, as 67% of our income, which represents our baseline funding, flowed through the CCG. This was then topped up by NHS England to reflect our cost base and COVID spend by a further 7%. And additional funding from NHS England for directly commissioned services of 11% and other non-recurrent income. We also received funding in year from the local authority, representing the Devon Care services that we provided at the time and other directly commissioned services, such as our sexual health service. Can we go on to the next slide, please? So how do we spend that income that we received? So the majority of spend is on staffing, representing 62 pence in the pound, and that's as we would expect, because the workforce is really the heart of the services that we deliver. The next big area of spend is around drugs and clinical services at 13 pence in the pound, so the direct costs of providing the care to our patients. Other costs are then around overhead and corporate costs of managing a complex organisation and running the range of estate we have across Barnstable and the wider community. Within other expenses is a multitude of smaller expenses, too numerous to list individually, and I know it's something that I've been asked previously, but does include research and development, education, transport, other fees, clinical negligence and Devon Care's costs. Can we go on to the next slide, please? So as I stated at the start, we've been funded for the additional costs of managing COVID during 2021, which from a revenue perspective equated to 8.5 million of additional cost. The majority of this was for backfill of staff absence, either for at-risk clinical staff having to self-isolate and do other work valuable to the organisation from home, or be other staff being absent due to having contact or through having COVID itself. Additional costs also were incurred for testing, supporting our workforce and expanding workforce where we could, and commissioning additional community capacity to try and free beds on the acute site to manage the COVID flows. Cleaning, locally procured additional PPE, protective equipment above the national stocks that we were allocated, and other infection prevention controls were the majority of the remaining costs we incurred. Next slide, please. In terms of capital, it really was an exceptional year for the Trust in terms of capital investment, and I think it shows true investment in the future of North Devon as an organisation. So as well as our normal annual capital programme on backlog maintenance and equipment, we had funding to complete the installation of our second CT scanner and updating our existing scanner. We were able to source off-site accommodation for non-clinical staff, which will enable us to maximise clinical activity on site. We had capital to adapt some of our estate to manage the COVID pathways, such as the extension that you may have seen to the emergency department to help us separate flows of COVID suspected patients at our front door. And finally, we were able to draw down the first element of capital for the implementation of our integrated electronic patient record, or the MyCare programme that Chris alluded to, which has a target go live date of July next year. Next slide, please. In terms of the slightly dry subject of the financial accounts, from an accounting point of view, under the temporary funding regime, we were able to meet all of the in-year expectations around break-even, capital costs and our capital resourcing limit, and to ensure that we were paying all of our suppliers promptly to ensure that we weren't disadvantaging any local businesses. However, we do have to recognise that from a cumulative break-even perspective, we have not been able to demonstrate break-even over the longer term period, and that was as a result of the previously reported deficit in 2018-19. Next slide, please. In terms of use of resources, again, we were able to demonstrate a positive use of resources position, although the overall rating did remain to 3 overall. All markers improved with the exception of the capital servicing limit, and this was due to the value of our exceptional capital programme compared to the level of our internally generated depreciation, which is in fact a positive story because of the additional investment we had in the Trust. Next slide, please. So finally, looking ahead to 2021-22, it's been a challenging year, given that we've had guidance separated into 2 halves of the year, and the financial settlement for the second half of this year was announced this week and for the next 3 years. And that's very welcome news to the NHS, and really great that the pressures we're under are being recognised. We do need to understand the impact that has at a local level though, and that's work that we're currently doing. So plans will continue to be focused on ensuring that we have the right level of resources to respond to the ongoing COVID environment, because it is still with us, and therefore we will need to continue to work within those constraints for a while longer. And we are also ensuring that we're maintaining our cost base and prioritising within those constraints that we have to ensure that we are mindful of financial stability in an uncertain financial regime. In terms of future capital plans, we'll continue to focus on maintaining our wider estate, and with the strategic ambition for the acute hospital aligned to the government's new hospital programme under our Future Hospitals programme, which Chris mentioned. So that's the end of the finance slides. I'm now going to hand over to Jason to present on the quality accounts.
Thanks, Angela. Yes, as previously mentioned, my name's Jason Lugg. I'm the Trust Director of Nursing for NDHT, and I was delighted to be appointed to this role in February earlier this year. I'm going to take you through a set of slides which just describe the outcomes from the priorities that were set in the previous year's quality accounts, and then I will just take you through what the quality objectives that we're working on for this year. Next slide, please. So I'll start by highlighting the 3 quality priorities that were set for the 2021 year. And as you can see, they focused on staff health and well-being, falls and bone health, and ensuring clinicians see and act on results as a priority. I will discuss each one of these in more detail as I go through the slides and provide you with an update on the outcomes. Next slide, please. So looking at the first objective of staff health and well-being, we set out a number of themes that we wanted to progress during the year. These included providing breastfeeding facilities, increasing activity at work for sedentary workers. We plan to take part in the Public Health England Healthy Weight NHS declaration, and we're keen to pilot a staff dietitian. We were also looking to implement a staff network for staff who have caring responsibilities, recognising the real challenges many of our staff have in balancing work life along with caring for someone outside of work. Next slide, please. So as Chris has highlighted, the COVID-19 pandemic challenged the trust in a very significant way and meant that we had to refocus our priorities in terms of the staff health and well-being. The commitment remained more than ever that we had to support staff through what has been and continues to be an extremely challenging time, but our priorities had to be changed to reflect the challenges provided by COVID. So our focus moved to keeping staff safe by ensuring the provision of personal protective equipment, making sure that we had the associated guidance for staff to use and the necessary training. We had to redesign much of our clinical and non-clinical estate to allow for social distancing measures. We had to support staff, as Angela has mentioned, in terms of being able to work effectively remotely where that was possible. We needed to create rest areas, recognising the challenges around social distancing, but ensuring that staff had access to appropriate rest during their shifts. And a significant undertaking in terms of the risk assessment process, both of clinical areas, but also of staff individually, to make sure that we were absolutely doing everything we could to protect staff and patients during COVID. We also developed and promoted the available staff resources for health and well-being. I mean, during the COVID pandemic, we know that for our staff, the challenges have been long, continued with no real respite. So ensuring staff had access to appropriate health and well-being resources remained a strong commitment. Next slide, please. Our second objective was focused around reducing falls and improving bone health, and we committed to a number of actions, as you can see on the slide. So we were keen to ensure that all staff could complete a lying and standing blood pressure check, recognising this is important, to identify drops in blood pressure on standing as a falls prevention strategy, and that they were recorded appropriately. We wanted to formulate a falls forum that transversed across acute and community so that we could really understand collectively how we could prevent falls and how we respond to falls when they occur, and ensure that the learning from falls when they unfortunately do occur minimises the reoccurrence in the future. We were looking to trial a falls in 15 approach, which is effectively a rapid review when a patient does fall, so that you very quickly ensure that the appropriate aftercare is put in place and the support is applied both to the family, the patient, and of course the staff that are involved. And we also plan to have a falls workshop conference in 2020. Next slide, please. And a similar position to the previous objective in terms of, much of this was derailed due to COVID. However, considerable work has progressed and continues to progress with falls. So whilst this hasn't transformed over to being a quality objective for this year, there is a sustained work programme being undertaken, within the trust on this very outcome around preventing, reducing and responding appropriately to falls. I mean, our data tells us that between 97 and 98% of our patients that are admitted to NDDH do not fall, but nevertheless we completely recognise the impact of an inpatient fall for those 3% of patients when it does occur. So work has been undertaken to improve ward level documentation and that focus around lying and standing blood pressure checks and recording, and focused teaching has taken place in clinical areas. It is still our intention to create a falls forum, and this has been incorporated into the falls annual work plan. We have spent time improving our insight into falls within the organisation so that we really understand the themes that increase the risk of a patient falling. And this is enabling us to develop targeted strategies to further reduce falls risk and occurrence. And we have also recently revised our falls policy and associated processes to support all of that ongoing work. Next slide, please. And our last priority for 2021 was to ensure clinicians see and act on patient results as a priority. And this involves setting up something called CRIS Communicator, which is effectively an email that is sent to clinicians when a critical or unexpected result occurs. And we also plan to review our system for clinicians to see blood results. Next slide, please. So the task and finish work was delayed, but has now undertaken the scoping work required. And I'm pleased to say that CRIS Communicator has been set up and is working across clinical areas. So we've identified a number of key areas where the risk remains high, and the medical assessment unit, due to the throughput of patients through that area, is one such identified area. And we're strengthening the risk of not identifying results in a prompt way by also building in other layers of activity where ward clerks and secretaries are also supporting clinical staff with identifying test results and flagging them appropriately to clinicians. And we've talked a little bit about the benefit realizations of MyCare going forward, and we've highlighted the need for electronic requesting for other specimens, particularly around virology and microbiology. And we're confident this can be enabled by the implementation of MyCare in July 22. Next slide, please. So moving on to what our quality priorities are for this year currently, we've identified 3 specific areas that we are currently working on. So the first area is patient experience, the second is just culture, and the third is pressure ulcers. Next slide, please. So we are absolutely committed as an organisation to boost the excellent work that we already do and the focus that our patient experience team already have at NDHT to improve the patient's experience of all of our services. So we're currently developing a joint patient experience strategy along with our colleagues at the Royal Devon and Exeter, which will be overseen by the Trust Board. And this strategy will ensure that we have the systems and processes in place and puts people at the centre of what we do and reinforces that patient experience is everyone's business regardless of role. We've developed some key principles that intend to underpin our strategy, and we are currently seeking feedback on these principles, and I'm hopeful that you have seen the invite to provide feedback on our patient experience strategies through the various communication channels, internally, externally, and via social media, and that you will provide us with your valued feedback on whether you think our principles are appropriate. And essentially, we are committed to implementing strongly the what matters to you concept, recognizing that we need our patients and their carers to inform us of what really matters to them in terms of their journey through our services, and help us in that co-design process by meaningful patient involvement and engagement activities. Next slide, please. The Just Culture is focused on developing further our work on a just and learning culture, which is an important role in creating a healthy working environment for our staff and improving patient safety overall. It has a strong link with the National Patient Safety Strategy, which is coming into force next year. Considerable work has already been undertaken by the people team to implement the Just Culture principles into our formal and informal employee processes, and we are now expanding this concept into how we manage patient safety incidents. So we're developing a local training programme for staff involved in leading clinical incident responses, and we're working to understand the needs of our staff and how we can better support them in creating psychological safety following a clinical incident. The priority strongly supports our ambition to increase our focus on learning from clinical incidents across all professional groups and services, and reduces reoccurrence and maximises safety. Next slide, please. And our last quality objective for the remainder of this year is to further reduce pressure ulcers across NDHT. And we've deliberately separated this objective so that we recognise the unique and different challenges that occur across acute and community. So at North Devon District Hospital, we're working to focus on the earlier identification of pressure ulcers, particularly at what we call a category 1 level, because we feel very strongly that focusing at an early stage, and more importantly, appropriately intervening at an early stage, will prevent the opportunity for a pressure ulcer to develop to a different category. Within the community, there was a whole different set of priorities there in terms of, or challenges, I should say, in terms of, obviously, we don't provide round-the-clock care. So we're developing a deeper understanding of what actually the challenges are that cause pressure ulcers in the community. And that deeper understanding, we're hoping, will allow us to implement targeted strategies specifically and bespoke to the community setting. And we are using quality improvement methods to do this. And the community team have already been implementing many QI projects to achieve this. And we were delighted that this approach has been acknowledged recently with one of our community teams winning a health service journal poster competition, specifically around pressure ulcer plans in the community setting. So that's kind of a whistle-stop tour really through quality objectives and quality account from last year and this year. And I'm now going to hand back to Chris.
Thank you ever so much for that, Jason. So that was the year that was. Looking ahead to 21, 22 and beyond. Next slide, please. I guess the most important thing for us is staff wellbeing and resilience. Our staff have been through the toughest time ever. It's so important we can not only recruit more staff, but actually we can retain the fabulous staff we've got as well. And what you tend to find with carers is that very often the last person they look after is themselves. So we're putting an awful lot of time and effort into ensuring people take their leave, they spend some time with family, they recharge their batteries, and we also provide not just the right support for staff when they need it through Hannah's team, and there's a fabulous occupational health team and HR team to support staff, but we also try and give staff the right tools and environment so when they come to work things are there for them. So there's a massive emphasis we're putting on staff resilience at the moment, because this is a marathon, not a sprint. The more that we know about the pandemic, the more we realise we will be living with it for some time. And whilst we live with the pandemic, maintaining safety for our patients and our staff has to be a number one priority, and it will be so. But we also have to recognise that the whole NHS is looking at such a big waiting list now that's pretty unprecedented. So, you know, we have to use this crisis as an opportunity of looking at new ways of working, as well as looking at ways of being more productive with our capacity. So it's a real focus for us about how we reset and recover alongside how we support staff and we keep things safe. That said, there's some big things that we've still got to deliver both this year and beyond. We are looking to submit our integration business case to our regulators later on this year. That will effectively give us a roadmap for how we're going to really see the benefits of coming together. It'll allow us to share, I mean, not only are we seeing the benefit of having the same electronic patient record system, but also we're seeing the benefit of sharing some of the local innovations that otherwise sometimes don't get replicated. So a good example would be the drive-through. That was a fabulous idea. If we weren't working so closely together, we probably wouldn't be looking to look at that and replicate that elsewhere. So the benefit for both the RD&E and North Devon by coming together is finding new ways of working, because the old ways won't take us to where we need to get to. Next slide, please. And then my last slide is just picking up some of the big things that we've got to do as well. So Adrian and team are leading the rollout of My Care to Northern Devon. We had some recruitment events over the last 2 or 3 months. We've had a fabulous response from Northern Devon staff, from both the hospital and the community, from people that want to get involved in implementing this really exciting system. And the system, which is called EPIC, is truly best in class. So we have got something that is I think, and I know Adrian thinks is world leading. We are also really excited about our Future Hospital programme. This is a once in a lifetime opportunity of putting some really fabulous facilities in place that will serve our population and act as a legacy for the next kind of 30 years plus. So we're really hopeful we'll get the green light fairly soon to move to outline business case stage, and that is going to take quite a lot of clinical and operational input to make sure that we're building the right facilities for the future. And as I said earlier, we'll continue to develop some of the partnership work that we've got, most notably the strategic alliance that we have between North Devon Healthcare Trust, the RD&E, and Torbay and South Devon. But moreover, the work that we will do and increasingly get involved in through our integrated care system. So I think there's huge opportunities for us. We're moving from a system that in the past has probably been quite competitive, where people have been jostling for resources or trying to use competition to drive improvement. What we're now doing is collaborating together. And anyone that kind of has researched health knows that without a really strong social care foundation, without really good links to housing and primary care, a secondary care health system just can't function. So I think, we will continue to be really strong partners. So we've got to manage COVID and recovery, but we've also got to manage quite a lot of big programs and begin to work very much more as a key partner in this bigger integrated healthcare system. So I think a lot to be excited about, but also a lot for us as a board to be monitoring and to make sure that we can do it all, because it is a huge agenda. And I just want to say a massive thanks to all of our staff, wherever you work. What an amazing year it's been, and I know that by continuing to do what we're doing, we'll continue to improve and take the trust forward. So I'll end there, James, if that's okay. And I think we probably now move into the questions and answer session. Over to you.
Thanks, Chris. I think you're probably right. But could I just thank Chris and Angela and Jason for their contributions to that presentation as well. So we've got the chat bar, as I mentioned. For those that aren't familiar with MS Teams, at the top of your screen there's a text cell. If you click on that, that will give you the ability to type any questions that you wish to, and we'll come back to those. But we have had some questions in advance. So just prior to moving to the questions, there is a note in the chat bar where Steve Kirby, who is a long-standing non-exec director at Royal Devon Exeter, but a new member of the trust board at NDHT, has noted that there have been some outstanding results in the community in respect of pressure ulcers for chair-bound patients, and he's had a thumbs up from our nursing colleagues, so it must be right. Brilliant, thank you. So if we can move on to the questions, I'll read these out, the four out that we have, and allocate, ask colleagues to address those. But as I say, please add any further questions in the chat bar. So the first question that we have is from Deborah Crocker. What happens to those people that are unable to travel to Exeter from rural areas in North Devon? Is it just the wealthiest members of society that are able to access treatment? Will transport be available for the rest of us, or are we just left to die? So thank you very much, Deborah, for that question. I was going to attempt to answer that myself and then pass across to our medical director, Adrian Harris. So we recognise, both as two trust boards and as a wider ICS, that there are already unacceptable health inequalities within Devon and frankly across England and the UK, and there is a real commitment to improve those health inequalities, i.e. to reduce them, and that's a belief that's very passionately held, and there's a real commitment also to achieve that by not averaging down. It's easy to reduce inequality by averaging down. It's much more difficult to improve the lot of the less advantaged. We're also really conscious that when we look at transformation, that does give us the opportunity to reduce inequalities, but without focus, it could actually inadvertently increase them. So we're really, focused on the importance of using transformation to reduce health inequalities, and we are very grateful and acknowledge that we have a once-in-a-lifetime opportunity to do this, as Chris mentioned, through the very significant capital programme that's been committed to Northern Devon. So that's circa £250 million. So that gives us the ability to invest. I mean, on the specific question, we are absolutely committed to ensuring that urgent and emergency care is provided in Northern Devon, and that the specialities that are required to support urgent and emergency care will continue to be supported in the north. I mean, the first golden hour of life is very well understood, and we all understand the sort of transport challenges that we have. It isn't just about distances, it's about time to access care. So there's an absolute commitment to do that. And as I say, the almost £250 million which has been committed to Northern Devon is specifically committed for investment in Northern Devon and not in wider Devon. So we've got a great opportunity to improve health inequalities, and as I step down from the board, I'll certainly be coming back to haunt anyone who doesn't support that, and I'll be coming along to these meetings with my stick and banging the floor demanding that health inequalities are reduced. Adrian, over to you.
Thank you very much, James. Can I just check you can hear me? Give me a wave, James. Can you hear me? You can. I have very little to add to what you say, James, bar to reiterate that we are absolutely committed to maintaining urgent and emergency services, and indeed, if possible, adding to the services that we provide in North Devon as part of the relationship with the RD&E. And we now have a number of consultants and other healthcare providers coming up the road from Exeter, providing care in North Devon that previously was provided in Exeter. So I'm optimistic that, if anything, we'll be able to turn the tide. Now, clearly there will be challenges around delivering that, but I think a huge weapon in that challenge is EPIC that you mentioned. So next year we will turn on a comprehensive electronic patient record in North Devon that is the sister or brother of the system in Exeter, and we will operate them as one system. And that allows consultants and other senior healthcare workers to deliver virtual care in a way that we've never been able to before. So I'm really optimistic that this will allow us to keep patients in North Devon who previously we might have had to transfer. So I see great reason to be optimistic in this area.
That's great. Thank you very much indeed, Adrian. The next question we have is from Kay Moore. My apologies, I don't know any more about Kay Moore, but this matter concerns me greatly and affects those who use A&E as a patient or staff. Why can they not have a separate space for those who are drunk or suffering drug abuse, etc.? And again, if I can come back to you, Adrian, and perhaps Jason could also comment.
Yeah, thank you very much, James. I am an A&E consultant, so this is a subject that is very dear to my heart. And I anticipate the essence of this question is around the waiting area for patients who are intoxicated or suffering the other effects of recreational drugs or other forms of confusion, as opposed to the clinical space, because we do provide separate clinical spaces, as I'm sure everyone appreciates. This is something that's discussed within the circles of emergency medicine, A&E medicine on a regular basis. But of course, there are a number of practical problems with it. The first being deciding who fits that category. And whilst it is occasionally extremely obvious who fits that category, a lot of the time it is in no way obvious. And then sadly, the primary problem is one of expense. To support a second waiting area is extremely labour intensive. And I know of no department in the UK that has the resources to do this. I think if we had an infinite amount of resource, and that doesn't just mean money, that means staff, this might be something that we could consider. But simply there just is not the resource in terms of staff, space or money to support it to allow us to do this.
That's great, thank you, Adrian. Jason, have you anything to add to that very comprehensive answer?
All I was going to say is that as an A&E nurse, this is dear to my heart too. But no, I don't have any. I think Adrian's covered that off. I have nothing more to add.
Brilliant. Thank you both. If we go on to the next question, please. This is from Terry Elliott from Ilfracombe. The Trust has experienced difficulties in recruitment across most departments. Part of the reason for this lies in the current lack of available or affordable housing in North Devon, and this can act as a deterrent for prospective applicants. Similarly, there is a very poor public transport network across parts of North Devon providing access to the hospital. Not every member of staff has access to a car, but the chances of being able to travel to or from work by public transport, especially after 6 p.m. or from smaller towns or villages, is simply non-existent. Terry goes on, as the biggest employer in North Devon and one committed to equality and hopefully to reducing the carbon footprint of the Trust, what measures are you taking to help tackle the issues of both lack of accommodation for potential staff and the lack of decent public transport to the hospital for employees and patients alike? And if I could turn first of all to Hannah Foster to answer that. Thank you, Hannah.
Thanks, James. So first of all, I mean, we have had some success in recruitment in different ways. We've done a number of new things in recruitment. If anyone looks at our website and our jobs, there's a fantastic video. And what we have seen in the last year is that we have attracted some people who want to move out of some big urban centres. So we have had some success in recruitment, and in international recruitment, we've dedicated some specialist expertise to really search and find candidates and filled some roles we've really struggled to fill in the past, and often being much more innovative than other NHS employers. It doesn't mean it's not a challenge. It is a challenge, and you're quite right. In the housing situation, particularly more recently, has become more acute. Longer term, there is we have a lot of thoughts as part of the Our Future Hospital plan around what we can do around our housing, and I would love to think that we can be a real training centre, real attraction where our housing is part of the offer, that we can really create a centre of excellence for training as part of that Our Future Hospital, with a new hospital and great housing. It is not, the accommodation we have on site now is not great, but it is fully utilised. So we are providing some housing to our staff now, and we do have a longer term plan. Being honest, some of my team spend time trying to help staff find housing, and that is the nature of the beast. But we are fully engaged in the local discussion about housing for our workers. But we do a number of things to try and find temporary housing in the short term to support people. In relation to public transport, we have had discussions with Stagecoach about what we can do on buses, particularly from the station and that sort of thing, but it is a challenge. Things have been done on parking, and obviously it's been good for staff. We've had free parking during COVID, which has made it easier, and of course more people working from home and some of the space that Angela talked about earlier does mean we are creating more options for people around flexibility. That doesn't work for all our roles, and it doesn't work when people are doing frontline clinical roles, but all those things have taken some of the pressure off people needing to be in Barnstaple every single day, or being in the same place every single day. So we are managing it, but we are part of discussions with local employers about how do we help more with long-term housing solutions. And with Chris and his team, we are trying to think about if there's more we can do, particularly when we're welcoming international workers, to support them at least temporarily until they establish themselves into the community.
That's brilliant. Chris, did you want to add anything to Anna's?
No, I think Hannah's covered it. To be honest, it's something we recognise, and it continues to be a priority. And we'll do whatever we can through our own developments on site, but also by influencing others. So, yeah, a recognised issue.
That's great. Thank you,
James. Sue's posted in the chat. Sue's just posted in the chat about the creche, and she knows well about this. But it is part of the Our Future Hospital plan. We are very keen that that would be something we would include as part of the Our Future Hospital plan.
Thank you, Greg. That's really helpful. And I think there is a real recognition within the board and more widely that with the almost £250 million promised to Barnstable under the Our Future Hospitals programme and the circa 1.2 billion promised to Devon, you know, that can have a huge impact, not just directly on the NHS, but on the skills agenda. And the team's working very closely with Petroc, for example, and on the on things like housing and the various other determinants of healthy lives. So there's a real important. It isn't just the 1.2 billion; it's the multiplier effect on that. So I think there's a real responsibility on the board to ensure that we get every bang for that buck once it's forthcoming. Thank you, Hannah. Thank you, Chris. So the final question we had in advance was from the Tyrrell League of Friends in Ilfracombe. Several members of the public have contacted the League concerns that people are being asked to travel to Bideford from Ilfracombe for X-rays. There is capacity at the Tyrrell for X-ray, but this has not been operational for months due to staff shortages. It is difficult enough for some people to access provision at the district hospital, but for many others, there is no way of getting to Bideford due to transport or mobility issues and cost. Could an update be provided at the AGM, and if not, would it be possible to get a written response? So I was going to ask John to address that. Thank you, John.
Thanks, James. So good evening, everyone. I'm John Palmer. I'm the new Chief Operating Officer. It is absolutely great to be here, and what a privilege to be serving this population and this organisation. I've really enjoyed my first few weeks, so thank you very much. This is an important issue, and Chris referred to some of the ongoing staffing challenges that we are having as a result of COVID. And there's no doubt, as the longer march is now upon us, that staffing is becoming really our biggest day-to-day issue in terms of managing our positions. And it's no surprise that in some of our areas that are always a little bit difficult to fill, then we feel it most strongly there. And certainly sonography and radiography are two areas where we always struggle. And COVID has kind of revealed, I think, the level of challenge that we have. So it's absolutely right for the League of Friends to be tracking this position. And as colleagues will know, that at the beginning of COVID, we actually couldn't deliver the service at all, either in the Bideford or Ilfracombe sites. And then as we've gone through towards the second wave, we were able to re-provide the service located in Bideford, which has just allowed us to use the workforce to the best available level that we can and get a bit of productivity to try and catch up. So as matters stand at the moment, we still have quite a lot of challenges with maternity leave, COVID-related sickness and sickness and self-isolation. And that means that actually, despite the fact that we've made a number of immediate appointments through the last couple of months, we actually haven't really got to a better service level. We're sort of back to where we started, really, which is giving us a challenge. So we've recently signed off through our operations board for about another £450,000 worth of resource, which would be another 6 whole-time equivalents. And so at the moment, in the first wave of recruitment, we've got 5 whole-time equivalents who are being trained, and soon enough they will be operational and keep us at the same level that we are now. By the turn of the year, the further 6 whole-time equivalents will come into place. And I think, being entirely honest about it, it is at that point that we'd be able to look at a provision that gets both Ilfracombe and Bideford back up and running. So we will continue to risk assess on a daily, weekly basis, and if we can start to re-provide on both sites, we will. But really watching the tail of recruitment come through and the amount of time it takes to train people once they're in place, I think the new year is the best that we will be able to do at this stage. I will, of course, write to the League of Friends and give updates as we go through the next couple of months.
That's great, John. And that is, I appreciate it's taking a bit of time, but that is very positive news. I'm sure we can rely on our friends at the Tyrrell League of Friends to continue to hold us to account on progressing that at pace. So thank you for that. On a similar matter, and I'm going to come back to you, John, if I may. In the first instance, we have a question from Sue Matthews. What progress has been made in recruiting to MIU A&E staff numbers to support the teams at NDHT and the MIUs?
So I'm afraid I don't have brilliant news on this front as it stands. So I think everybody knew that we were out for recruitment, and we've gone through 2 rounds of recruitment now for specialist nurse positions. We had 7 applicants and only 1 was appointable, and that individual's going through training now, so we can bring them into the rotas. So given current conditions and the relatively high COVID risk that we remain at, we're not going to be able to restore our MIU position soon. But I have to say that there's been excellent ongoing dialogue between the League of Friends, Ilfracombe Town Council and our own organisation. Most recent meeting was only a few days ago, and I think we are still looking at a number of local solutions that reflect the kind of things that we've been doing so far. So we know that we tried the RNLI resort-based solution over the summer. And we know that we've been providing through the offices of the CCG the weekend cover through Ilfracombe MIU and the first care ambulance proposal, and we did actually extend that a couple of weeks ago until the middle of this month. So the task and finish group that's being formed by the CCG, our own organisation, and a number of local leads is going to continue to look at those kind of solutions and see if there's some things that we can do that will just continue to provide some local confidence that we want to provide services as locally as possible to our patient population. And then as soon as we have some COVID restrictions that pull back and we're able to be more successful with recruitment, we will indeed look to re-provide the MIU, as we've mentioned previously in board meetings, because that's a service we're commissioned for, and it's a service that we know is really important to our community.
That's great, John. That's very helpful. Jason, was there anything you wanted to add to that? I'm afraid it was very comprehensive again. But...
No, I think that was very comprehensive. Thank you, James.
That's great. Thanks, Jason. We have a note in the chat from Elizabeth, who notes that, adding to the annual report, congratulations to UpGI on academic recognition. Many thanks for that, Elizabeth. Would it be possible, Adrian, to take that back to the team and thank them, and all John and Jason?
Of course.
Thank you. That's great. I'm not seeing any other questions in the chat bar. Does anyone wish to raise a virtual hand or a physical hand to raise any questions? I'm not seeing it. Could I just check with Mel? Mel, am I missing anyone?
No, you're certainly not, James. I can't see any hands.
Okay, great. Well, if there's no further questions, if I could just go back to the point that I made at the beginning of the meeting, that if the proposed merger is approved and goes ahead in the spring of next year, it does. We've benefited from a really engaged group of staff colleagues and members of the public in Northern Devon who do provide that challenge to us to get better in the services that we provide to our communities. So if I could just make it clear again that when we advise the process for recruitment of new members and governors, if you could look at engaging in that, because that does give you, I think, quite a powerful way to maintain and even increase the level of engagement which you provided to us. But if there's no further questions, Chris, were there any further points that you or any of the exec wanted to raise?
No, James, other than I'd just like to put my thanks on record to you, as this is your last AGM. Feels a bit strange me saying this, but I know you've thanked everyone else for their efforts over the years, but I think you've been quite extraordinary, and I'm sure you'll carry on continuing to hold us to account, as you said. But just wanted to thank you on behalf of the board for what you've done.
That's really kind. And as you say, not my last AGM, merely my last AGM as chairman. Okay.
Indeed.
I look forward to coming back. Thank you very much indeed for that. Well, could I just reiterate my thanks to both to colleagues, but also to staff colleagues and to members of the public for engaging in this process, and look forward to seeing you again next year, potentially as part of the larger organisation. But thank you very much indeed for coming tonight. Thank you. Bye.